Hello everyone, I'm Dr. Abhishek Vash. I'm orthopedic consultant in Indraprastha Apollo Hospital. So today we are going to discuss a very important topic. There are many questions, myths related to spine problems, and you face it all the time. So today we are going to answer those questions very specifically, and evidence-based answers will be given to you. So let's see. The chances of anyone having a lower back problem is more than 80%. Any person you meet will tell you that they have experienced lower back pain sometime in their lifetime. Majority of these back pains are self-limiting and mechanical. And believe me, out of 100 cases, only 3 or 4 cases will require surgery. So there is a very big myth in all people's mind that if we have a spine problem, then we may need a surgery, but actually it is not true. So finding the diagnosis and why the pain is happening is the most important thing. As we know, low back pain is the commonest problem, yet it is most misunderstood problem. There is over investigation, unnecessary MRIs are done. Patients keep on wearing belt for long times, and they restrict their activities according to their own thinking, which actually worsen the outcomes rather than improving them. So today we are going to find out what is right and what should be done in such cases. So we are going to take 5 important questions. Number one will be based on when is MRI required. Number two is when you should use a belt and when not to use it. Number three is what are the types of injections which we can give for back pain relief. Number four is how what restrictions are required for low back pain and what not to do, and what are the recent advances. So first of all, we should know what are the red flags if a patient comes to you for low back pain. If the patient is having fever, weight loss, if the patient is saying that my clothes are getting loose, मुझे बेल्ट जो आती थी अब वो नहीं आ रही है, अब वो बहुत ढीली हो गई है. Yeah, there is history of cancer in the family. The patient is not eating properly, not sleeping at night. There is a major trauma history, or the patient is having neurological symptoms like weakening, bladder bowel involvement. These are all red flags. If you see them, then the patient requires investigation and further management as soon as possible. When is MRI recommended? So, if there are any red flags which you see, which I have already discussed, and if there is a severe or prolonged neurological deficit which the patient is experiencing, if you suspect infection or a tumor, so if you do a blood investigation, you will see the ESR is raised, CRP is raised. If you suspect tumor, there is a mass, family history, or immediate sudden increase in size of some lesion around the spine. So you suspect tumor. Yeah, and if there is a pain which is not resolving for more than 6 weeks, even when the patient is taking treatment in the form of medicines, physiotherapy, rest, then MRI should be done. But you should know, MRI is not for diagnosis. It is just to confirm your diagnosis. So you should have made a diagnosis based on a clinical examination and suspicion. MRI will just help you to plan the treatment and grade the problem. It is just a tool which will help you. You should not just rely on MRI reports. Yeah, the surgeon should know how to read the MRI films because films are, it is objective thing. A report can be made by a technician. The technician can make a mistake. So you just should not rely on the report. And MRI always should be selectively done because sometimes even for a normal person, if you do an MRI, you will find something, out of the blue coming in the MRI. But this is not causing the symptom to the patient. It will cause unnecessary fear and overdiagnosis, and sometimes over treatment also. So when not to do an MRI, you should know this. In any cause type of acute pain, MRI should not be done because acute pains usually resolve on their own in less than 6 weeks. MRI will not do anything to fast the treatment. If there are no red flags, don't do MRI. If the patient is improving with your medicines, rest, physiotherapy, then you should not do an MRI. And the patient has normal neurology which is not deteriorating, then also you should not do an MRI. When should we go for surgery? So, surgery is an exception, it is not a rule. As I told you before, also, out of 100 patients, only 3 or 4 patients of back pain will require surgery. So, most common indications are patients who have done all sorts of conservative management treatments and has failed. The pain is not going away, it is deteriorating for more than 3 months' time. Then you should consider surgery. If the patient is getting neurological symptoms and they are progressing, the weakness is progressing, the patient is having bladder bowel involvement, and it is affecting the quality of life, then surgery is indicated. Cauda equina syndrome. This is a medical emergency and it usually requires surgery as soon as possible because when you see the symptoms, saddle anesthesia, bladder bowel movement involvement, bilateral leg weakness, so this is a surgical emergency. It also has medico-legal implications. If you don't treat cauda equina syndrome fast, then the patient may have a long-term complication. So this also has medico-legal implications, and you should know how to identify the syndrome and get it treated as soon as possible. The next very important question, which most patients and sometimes doctors also get confused in, is when to use lumbar belts. So, what is first of all the purpose of belt? One should know that belt is not a treatment, it is just support. So, it reduces the micromotion, provides some proprioceptive feedback, causes pain modulation, and is also good for psychological support. So, when the patient is wearing a belt, they know that there is a back problem. They don't forget it and they don't bend and make their back pain worse. So, the purpose of lumbar belts is that. There are many types of belts which are available, but if we divide them into three types mainly, one is a soft lumbar belt, which is usually used in acute pains and sometimes to mobilize the patient early. Then the second one is semi-rigid belt. It is used in cases of disc prolapse and pain which is coming to the legs or called the radicular leg pain. The third type is a rigid brace. This is used in cases of instability, listhesis, osteoporosis, or osteoporotic vertebral fracture. And there is a very good paper, a review by in Cochrane, which confirms that lumbar belt is just a support which helps in short term, not in the long term. In fact, in the long term, it may cause more harm than good. What duration a lumbar belt should be used for? Usually 2 to 4 weeks. A lumbar belt should not be used after more than 6 weeks because it will reduce the muscle strength. The patient will get habituated and it will further weaken the back muscles. And that is why you should start weaning the lumbar belt. So if the patient is wearing the lumbar belt for most of the time of the day, ask them to start using it only while walking or going outside and then eventually get rid of it. And start weaning off by adding some exercises to strengthen the muscles which were weakened because of the use of these supports. So there is ample of evidence showing that it is only a short-term pain relief. Long term, there is no much benefit. It is just a support and it's not a treatment. The muscles are at a risk of getting deconditioned. So use of lumbar belts and the type of belt should be done selectively by the physician. Now, there is another confusion regarding low back injections. There are many sorts of injections we'll discuss shortly, and they could be diagnostic or therapeutic or both. Usually, when doing these injections, it is ideal to use image intensifier to go to the ideal exact position And again, this is not a specific, definitive treatment. It is just an adjunct and help in pain management. Most common type of injections used are epidural steroid injections. So what they do is they reduce the inflammation, causes short-term pain relief, most commonly used in cases of disc herniation with radicular symptoms. And the patient after pain relief can go for rehab and strengthening of the back muscle. The other type of injections are facet joint injections. These are more common in patients who have extension-based back pain or postural pain. So this is also diagnostic as well as therapeutic. The other type is sacroiliac joint injections. These are injections which are given in patients who have more buttock pain, pain on sitting, and rotational or transitional movement pain. So this injection will help in such condition. After the injection, patient is advised usually not to lift heavy things for 3 to 5 days, and they should not go for extensive rehab or physiotherapy for at least 2 to 3 days. And also watch for red flags. Red flag means no neurological symptoms, bladder bowel involvement after the injection. The physiotherapist should take care that they should avoid intense heat in the area of injection, no forceful mobilization uh, after 2 or 3 days of injection, and they should start again gradually and then progress to strengthening exercise. So, another question, why forward bending is restricted after surgery or any procedure in the back and when it should be done? So, usually, what happens when we bend forward, the disc pressure increases. This has been studied in ample studies. And what it causes is provoke nerve compression, nerve irritation, inflammation, and it also causes delay in healing in acute phase, for example, after surgery. So it should be restricted in certain conditions like acute disc prolapse, severe muscular spasm, and in immediate post-operative phase, for example, a discectomy, lumbar canal stenosis, listhesis surgery, or a fusion surgery. So this causes reduction in healing in acute phase, so it should be avoided. There are many recent advances which have happened. Uh, for example, to name a few, minimally invasive surgeries. You must have heard about ozone therapy or disc replacement or tubular surgeries. So there are many things coming, motion preservation surgeries. Many things are coming in, but most important thing is to identify the patient exactly which patient needs surgery. And most important thing, again, I'm emphasizing is out of 100 patients, only 3 or 4 patients will require surgery. Prognosis after these surgeries is excellent because now the techniques have evolved. It is no more scary surgery to go for. Usually, for radicular symptoms will go first. Back pain may persist for a few weeks after surgery, which will go with rehab and muscular strengths. So rehab is very, very critical after surgery. Now, physiotherapist is very important. Actually, physiotherapy is not an alternative to surgery. It is a foundation for fine care. So they are most important in cases of acute inflammatory phase, chronic low back pain, or in post-operative rehab time. And they are very important to motivate the patient, educate them, and give them psychological support. With this, the key take-home messages from this lecture should be that do MRI selectively. Don't think that any back pain, just do an MRI, you will get the answer. No. Find out what is happening, do a clinical examination, and only confirm your diagnosis with MRI where it is required. Surgery only for 3 to 4% cases, only in specific indications when there are red flags. Belt and injections are not the treatment, but they are adjuncts to treatment. And rehabilitation physiotherapy is the cornerstone for getting back to normal activity. Thank you. And I'm happy to take any questions or any discussion if someone wants based on this lecture or any other problem based to lumbar back pain, dorsal pain, cervical pain, injections. Thank you.